I'll be talking about amyotrophic lateral sclerosis. It's also known as Lou Gehrig's disease, and it's abbreviated ALS, commonly just shortened to ALS. So a little background information on ALS. It is a degenerative motor neuron disease, so it doesn't affect the sensory motor or the sensory neurons, only the motor. It's involved in both upper and lower motor neurons, and it's involved in the somatic nervous system, so the voluntary muscles only. There's no known cause and no known cure for ALS. Here I have a picture. This is just kind of a crude example. On the left is a normal neuron connecting to a muscle. On the right is an ALS neuron. You can see it's hardened, the sclerosis, and it's causing the muscle to atrophy. So that's just kind of a crude picture of what's going on. Okay, respiration is affected in ALS. It's the biggest concern, and the muscles involved in respiration atrophy, and usually respiratory failure is the cause of death. Initial onset is either bulbar or spinal symptoms. The bulbar is weakness in the speech and swallowing. That onset is typically correlated with a faster progression, so the survival rate is shorter. Spinal is weakness in the upper extremities and lower extremities. The speech characteristics are most often mixed, spastic, and flaccid dysarthria, so it results in a slow and imprecise articulation. And it's important to keep in mind that each person is different. The disease doesn't progress the same way in everyone, so these are just general characteristics. So next I have an example of the muscle atrophy. On the left there, you'll see a patient who has ALS. You'll see their tongue is atrophied, and on the right, it's in comparison to a normal tongue. So you can imagine how difficult it is to articulate when your tongue is atrophied like that. All right, the patient that I'm going to talk about today is Alan. He's a 56-year-old male. He's married and has 2 children. He works in the computer software industry, and he was referred to me by his neurologist. Alan was diagnosed with ALS about 3 months ago, and his initial symptoms were of the bulbar function, so the speech and swallowing are what's being affected first. He was generally in good health prior to his diagnosis, and his only current medication is Riluzole, and this is the only FDA-approved medication to treat ALS, and it doesn't treat the symptoms, it just slows the progression. He has no family history of ALS, which is fairly typical. Only about 5 to 10% of ALS patients have a genetic component involved. So Alan is coming to me today. He presents with complaints of slurred speech. He's having some difficulty with being understood by his friends and family. He's also having difficulty projecting his voice. He can't seem to speak up, and his family is complaining that they can't hear him. And then he's also having some difficulty with swallowing when he takes a large bite of food. So for his assessment, I'm going to start with the peak cough flow. His is about 400 liters per minute, and normal we want to see about 500 liters per minute. So he is low on that. And then I also did his forced vital capacity in both the supine and upright position. The supine position seems to be affected more by ALS than the upright. So his upright is about 5,400, his supine is 5,300, and we really want to see about 6,000 for those. The average decline for forced vital capacity is about 3.5% per month with ALS, so it is a rapid degeneration, and the forced vital capacity is the biggest predictor of this disease's progression. Next, I worked on his speech assessment, so I measured his speaking rate in words per minute. He's at about 150 words per minute. The norm is over 200, so he is talking a little bit slower, and his intelligibility is 95%, so he's still basically understood, but it is below 100% where he would like it to be. And then I also went ahead and did his ALS functional rating scale, the revised version. This is just a questionnaire that really serves to get a baseline for where his disease is at right now, and we can continue to do this to see how much it's progressing. The questionnaire includes questions about his respiratory, gross and fine motor, and his speech. His raw score was 38 out of a possible 48. All right, so next we'll move into intervention. For his breathing and swallowing, again, those are my biggest concerns. We really want to prevent him needing a PEG tube for as long as possible, delay that. So I recommend the breath stacking in conjunction with the supraglottal swallow. Breath stacking has been shown to really help with ALS patients in particular. Breath stacking should be completed about 3 times a day for 5 repetitions. And a basic how-to on breath stacking, it's using a resuscitator bag with a one-way valve to force the lungs to expand. So he's going to get more air on the inhale without exhaling. So we want his lungs to expand, and it results in a higher lung volume, higher peak cough flows, and it improves his airway clearance, which will help with swallowing. And then this used in conjunction with the supraglottal swallow will help him be able to swallow safely and prevent aspiration. Just a little review, we already talked about the supraglottal swallow last class, but it's the one where you hold your breath, take a swallow, and then do a small cough afterwards to clear the airway. So here it's just a picture of the equipment used for breath stacking, the respiration and the one-way valve, and they can choose to use a nose clip if they have a hard time not exhaling. And then intervention with Alan is really going to be focused on compensatory strategies. Muscle strengthening exercises are not shown to be helpful in ALS patients, so the evidence isn't there to support it. I choose not to take that route. It can be a psychological toll because it's really pointing out the progression of his disease. So really I want to encourage him not to shout, try and conserve his muscle energy, and be closer to his communication partner. And then I want to introduce AAC devices because eventually he will lose his ability to speak, and I want him to be comfortable with a device before that happens. Because he's in the software industry, I think he can manage a more complex system, so that's what I'm going to recommend, a computer with software that can really change and adapt to his needs. And then for him, voice banking may also be an option because he still has his voice. He can, kind of have common phrases that sound more natural that he can program into the computer. Okay, and then factors I want to take into account when I'm working with Alan is, again, the psychological component. This is a terminal disease. It progresses fairly rapidly. It's usually about 3 to 5 years of survival until the respiratory failure and end of life. So, I want to prevent aspiration, but I also want to consider, keeping him happy and having a good quality of life. Sensitivity toward his end-of-life progression, maybe helping him transition into palliative or hospice care. And then I want to keep my eye out for a cognitive decline because about 1/3 of ALS patients have dementia symptoms, but it's seen in the frontal lobe. So more of decision-making, executive functioning is really what I want to keep my eye out for. And then lastly, the follow-up for Alan. I want to see him every 3 months because this is such a progressive disease. I want to really monitor his speech, his swallowing, and his breathing. I want to work on getting him an AAC device as soon as possible so that he can really learn to use it, get to know it, be more comfortable with it. And then in the meantime, I just want to caution him, because he is at the beginning, I want to caution him to just slow down, take smaller bites when he's eating, try to be in a communication environment that's quiet, calm. Somebody else can really hear him. He can see them, they can see him. So really just the compensatory strategies for now. And then we'll just follow up and take it from there. Okay, so that's it.